So we're delighted to have Katherine from Duke University for the end of this morning before tea on machine learning for healthcare data.
All right. Can you guys hear me? Yeah? Okay, cool. All right, so I'm going to this is going to be a little bit different, I think, than most of the rest of the talks here, but I'm going to be talking about some of the applications that we've been working on at Duke in the medical regime, and hopefully I'll get to say a little bit about the kinds of inference methods that we've used in practice in order to try to solve these problems. And if you guys have suggestions for the kinds of inference methods we should be using instead because you have something much better in mind, please let me know. All right, so basically, I'm going to give kind of an overview of as much stuff as I can that we've been doing. So I'm going to start with, it's a little bit of a change from the abstract, but I'm going to start with some of our electronic health records work. So we do a lot of EHR work with Gaussian process-based models, and we've done some for chronic kidney disease. This was like a UAI paper that we had last year, and there's a meeting I'll plug. The people who run machine learning in healthcare, which is kind of a small group that's developed around using machine learning for healthcare applications. They meet in, we meet in August, and also for sepsis prediction. And then we've also looked at using basically factor analysis kinds of methods, modified factor analysis kinds of methods for trying to predict surgical complications and improve patient outcomes based on that. And then last, I'll talk about basically an app that I have being released called MS Mosaic. It's going to be released hopefully in like about a week. There's been a lot of bureaucratic holdup. What I'm probably not going to get around to talking about are the graph-coupled HMMs for predicting the spread of influenza, which is really cool work that we had at UAI maybe like 2 years ago, and maybe I'll describe it really quickly at the end. Okay, so let's start. Chronic kidney disease. So first, why are we interested in this problem? So this is an example of somebody who presented themselves. I'm at Duke, so we work a lot with the Duke health system, who presented themselves to the Duke health system, generally in an inpatient kind of setting, who had a whole bunch of problems, but their kidney function was measured, kidney function can be measured from a lab called creatinine for the most part, and this is a lab that's taken pretty commonly when somebody visits their doctor or becomes hospitalized. So at age 47, the person presented themselves to the hospital system. They had untreated diabetes, they had high blood pressure, their kidney functioning was normal, but there was some evidence of kidney damage, and the person wasn't getting regular medical care. So I should say eGFR is a measure of kidney function. It's an estimated measure of kidney function given by a linear equation, which is probably terrible, mostly off of that creatinine lab value that I just talked to you about. On the x-axis is the person's age. Okay, so this is the first time the healthcare system saw them. By age 49, the person's kidneys were functioning at 50%. At age 51, they were finally for the first time referred to a kidney specialist. So this is 3 years, 4 years after they first presented themselves to the hospital system. And you can see what kind of trend they're on in terms of their kidney functioning. 3 months later, they presented to the emergency room with kidney failure symptoms, and they started dialysis. And so what this means is that the person, on an emergency basis, had to start dialysis, which is a very risky procedure for them because all kinds of lines have to be basically inserted, and it's dangerous for their health. But it's also a very expensive procedure. This is actually the single most expensive procedure that can happen in a hospital system as a one-off procedure for an individual. Okay, so their kidneys failed, and they started dialysis, and they had all kinds of other problems, and they eventually passed away at age 63. And so when I talk to my colleagues in nephrology, basically they look at this and they're like, this is a bunch of missed opportunities, right? Like it's a bunch of missed opportunities to prevent or delay kidney failure. There are a bunch of missed opportunities to be able to try to treat the person for the various problems that they're having, or to be able to do other kinds of preventative procedures that would have prevented them from crash starting in the ER. So one of the things that they can do is that they can, if they know that you're probably going to go on dialysis like a year from now, they can like pre-insert lines so that you're kind of prepped to do this and don't have to do it in an emergency setting. But the real problem here is that when clinicians look at this kind of patient, basically what they say is, okay, when eGFR is 30, that's when we refer somebody to a kidney specialist, or that's when we start somebody on dialysis. And it's this threshold kind of thinking that prevents somebody from like looking at this trend and being like, well, this person's kidney function is pretty much tanking, and we think that in a short amount of time they're going to end up in serious trouble. Okay, so this means that 42% of people start dialysis having no prior nephrology care. And less than 10% of people with moderate chronic kidney disease and less than 50% of people with severe chronic kidney disease are even aware that they have something wrong with their kidneys. Okay, so what we really wanted to do is we wanted to say, okay, we can do certainly better than what's being done currently in the healthcare system, which is this thresholding, kind of like, are you above or below an eGFR of 30? But we can also do something better than, say, like Cox regression, which is say, okay, well, I think this is the time to whenever you're going to start dialysis. So what we wanted to do is we wanted to create this kind of predictive trend for the person's eGFR going out into the future, into time. So the thing that we thought of immediately to do that is use Gaussian processes. So there's a nice bit of work by Peter Shulam and Suchi Saria on starting to try to use Gaussian processes for doing this kind of longitudinal modeling. This was at NIPS in 2015. And the way this goes and kind of what we took our inspiration from is you have a Gaussian process, and basically the mean function that you're drawing your time series model from is determined by some kind of weighting on the covariates of the person, right? This is a population level effect. Some kind of basis, so the phi's are like basis functions, right? And so you have some kind of weighting on that. And the weighting that you have on that can depend on, say like a subclass. So there are many different kinds of trajectories that, say, a patient might have, a bunch of different ways that curve might look. And you want to be able to say, okay, I think that this person is part of like this subclass here, and so they're likely to have this kind of trajectory, right? So it's a weighting on a basis function around these subclasses, and then individual variations, right? So you can see on the right-hand side, you have some kind of population effect that's then sort of moderated by the subtype effect, which allows you to discover a curve, and then the long-term deviations kind of shift that curve for that subtype by the individual variation. And then there's variance on the mean given by a kernel function. This is an Ornstein-Uhlenbach. What we use is an Ornstein-Uhlenbach kernel function for our Gaussian process. And so one of the things that we're faced with in this chronic kidney disease situation is a whole bunch of different lab values, right? So you can't think of this as one particular trajectory, say for like eGFR. There is one trajectory for eGFR, but there are also a whole bunch of like lab values and things like that which are taken for each individual patient. So what you really want is some kind of multivariate Gaussian process kind of model. And that's what we worked on. That's one of the things that we worked on. So we want to capture some kind of dependence between these different GPs, right? So we can do this in a couple of different ways. We can look at the weights for their individual variation, and we can say we can correlate those basically using a normal distribution. And then we can also say that we think that the subtype that they correspond to is correlated across the different labs and across the eGFR longitudinal trend via a mixture of multinomials. And so we do both of those, and that's the way in which we introduce dependence between the different GPs. And so then we tested this setup. So we looked at 6 different variables of interest, EGFR, and 5 different lab values. We had 44,000 patients at Duke who fell into the category of having chronic kidney disease in a way that we could pull from the electronic health record system. And then for each patient, we say, okay, we're going to use data before time t in order to try to predict what's going to happen to them in the future. And we compared to basically like not introducing dependence and just looking at like factorized Gaussian process models that are not correlated, which is already significantly better than what they actually do right now. And so what we found is that when we looked at, say, like the absolute error, or how far off our predictions were at any point in time, right? So we had different time bands that we looked at evaluating how well we were doing, and we kind of averaged how well we were predicting over those time bands. We saw that basically this introduction of this dependence did really well in terms of improving the predictions off of our lab values. Another thing we looked at in the chronic kidney disease setting was trying to do joint prediction of EGFR or how well your kidneys are doing with all kinds of other adverse events that might happen to you if you have chronic kidney disease. So if you have chronic kidney disease, it's like if you have diabetes, right, this puts you at risk for a whole bunch of other kind of bad things happening to you. So one of those bad things is heart disease. Another one of those bad things is a stroke, right? So we want to be able to kind of jointly predict what we think is going to happen in terms of your kidney functioning with how likely we think you are to have one of these adverse events like a heart attack or a stroke. And so we had a joint model that we used in order to do this, and that joint model was basically like the model that I just presented to you from the previous set of slides, plus a Poisson process model, right? So the Poisson process model was basically saying, okay, I have events coming at some rate, and I'm gonna model these individually. And so we said, conditioned on the person's subtype and conditioned on all of their other parameters, we're going to say that these factorize, right? So this is our factored likelihood model. Okay, so the Poisson process model that we used in order to predict adverse events is like the pretty standard thing that you guys would first think of. It has a rate. The rate function is obviously going to have parameters which depend on the EGFR Gaussian process predictions, right? So the rate is dependent on, it's got a baseline rate, there's a coefficient vector and baseline covariates for that individual, but then there's a weighting of the expected mean and slope of the EGFR values that we're inferring from the Gaussian process. So in order to look at this set of data, people with both chronic kidney disease and some other complications, right, like heart disease or stroke, what we did is we looked at patients at Duke that had both, were both being monitored for chronic kidney disease, but were also patients that the hospital system had seen because they had some kind of heart attack or stroke event. So this was 24,450 patients. And we looked at their baseline covariates, which included their age and their race and their gender and whether or not they had diabetes in order to use in this model. And these are the kinds of results that we got. So basically, to explain this plot, so what you see with this black line is the mean prediction of what the EGFR is likely to be for that particular patient, and what you see in terms of this red line is the predicted mean likelihood of this person having an adverse event. So this is happening over time, right? So what's actually changing is we're shifting, the x-axis is time, and we're shifting what we're training off of and what we're predicting on. So on the top plot, we're saying, okay, anything to the left of here is what we're training off of, and then to the right is what we're predicting from. in the middle plot, it's here, and in the right plot, it's here. So you can see, particularly after the person has had some kind of adverse event, right, the chances that they'll have another one go way up. Okay, so that's basically what we've been doing in terms of chronic kidney disease. One of the things that we've been working on right now is sepsis. This work is going to be presented at ICML this summer. So another thing that the hospital system really cares about, and they probably care almost more about this than most other things, is being able to predict whether or not somebody is going to have a complication, an infection that they contract while they're in the hospital that is likely to endanger their lives. So they use this scoring system, which they call NEWS, and it's given here. And it's a really simplistic system, and so you can see there are different kinds of things that they're measuring from patients on the left, right? Like their respiration rate, their oxygen saturation rate, their heart rate, et cetera. And then they get a number of points, which you add up across these different bins, given what the patient is scoring, right? So if their heart rate is less than 40, they get 3 points. If their respiration rate is between 12 and 20 per minute, breaths per minute, then they don't get any points. And then they sum them all up and they look at the total score, and based on that total score, they decide whether or not to do anything. And so this is like both, again, very thresholdy, but not necessarily a great measurement. So you can see here for systolic blood pressure, right? If it's like above, if it's 220 or higher, they get 3 points. But if it's like 219, they get 0 points, right? So it's not very consistent either. And so there's been some work, because this is such a big, it's such a big thing for hospitals, and it's of such high cost, right? And it's of such high cost to patients if they end up getting one of these infections, because I think the mortality rate is nearly 50% if you have really bad, like late-stage septic shock. There's been a bunch of work within the machine learning community. I mean, not a ton, but there's been some on trying to actually do this kind of prediction. So for example, again, Suchisaria has a paper in Science Translational Medicine, which uses Cox regression to predict time to septic shock using 54 different features. So this is kind of what we take as maybe, this is the baseline of like what our hospital uses, and this is kind of like the baseline of what you see going on in the machine learning kind of community right now. It's not really a time series. What I should say about the previous paper is like it's not really, it's predicting time to septic shock, but it's only kind of a time series paper. And so one of the things that we really wanted to do, again, was to introduce time series modeling into the situation, right? I think that's like it's a pretty common theme in this work, right? It's like people aren't really kind of looking at the time or dynamic aspect of like what's going on. They're just kind of saying, okay, we're going to implement this threshold at this particular time, and if it's below this kind of score, then we're going to say that the patient has like sepsis, and if it's not, then we're not going to worry about it until the next time we take a measurement. Okay, so again, we kind of fall back on Gaussian processes in order to do this kind of time series modeling. And so one of our problems with the sepsis data that we're collecting from the EHR, again, we're going to see a lot of lab values and vital signs and stuff like this. At this point, we're talking about all people who have been admitted to the hospital, because again, sepsis is really an infection that's contracted while you're, typically while you're, it doesn't have to be, but typically while you're admitted to the hospital. Okay, so what's one of the big problems with this? One of the big problems is that there isn't a lot of consistency to when lab values are measured. A lot of vitals are kind of taken continuously, but a lot of labs, they could be taken at any point in time, right? So one of the things we really want to do is to be able to say, okay, we have kind of this irregularly sampled time series. We've got time series where certain labs might not have been measured at all for certain people, right? There's like a ton of missing data. And so we want to kind of use Gaussian processes in order to try to help us make this a more sort of standardized kind of observation kind of problem, right? So we're going to say, okay, we're going to take the values that we do have for the labs that we do have in the vitals at the times we do have them. We're going to feed these into a Gaussian process, kind of like a Gaussian process, again, whose different trajectories across the different labs are related to each other, right? And we're going to say, okay, this is our best estimate of if we had taken this lab at this time, what would it have looked like? And we're going to use those estimates at particular grid points in order to feed into a classifier, right? Okay, so basically we have a standard GP kind of setup. We're looking here at work, again, coming off of work by Ben Marlin at NIPS last year, looking at using Gaussian processes in combination with classifiers, right? So say we have a standard GP, and we want to link it up to a particular classifier. How do we do that? Well, we say, okay, our GP can give us some estimate of what is going on at the particular time, right? We can weight all of the estimates that we're getting from our different GPs across lab values, across vitals, in order to make some kind of guess as to whether or not this person has sepsis or not, or is in danger of having sepsis or not. We have some kind of loss function, which tells us for our training data how far is that off of the truth. And we want to minimize, with respect to the weights and the parameters, the expectation of the loss, right? So this is a pretty common kind of classification framework. So in the Gaussian process setting, this is pretty hard, right, to combine like a GP and a classifier in this way, particularly if you have lots of missing data and things are not measured all at the same time. And so what was nice about their paper is they looked at, okay, how can we do this from an optimization standpoint so that we can do these both simultaneously end-to-end and get reasonable results. And so basically it's like they have like a framework for learning GP parameters and classifier parameters end-to-end or at the same time, where they use the reparameterization trick that was introduced by like Kingma and Welling, or used by Kingma and Welling, in order to get gradients of the expectation, right? So you basically want to, in order to minimize this function, right, you want to take gradients of this kind of expectation of the loss, but that's kind of a hard thing to do, so you can swap the expectation and the gradient, and basically, like, they've got a trick for doing that. And so then you can approximate intractable expectations with a few Monte Carlo samples. This is often done using like one Monte Carlo sample in practice. What we found sort of empirically is that certainly in our case, using one Monte Carlo sample wasn't very good. And that might have been because our particular problem is too noisy. But this was realistically more like 10 in our case, right? So we take about 10 Monte Carlo samples in order to get this expectation. And then we use conjugate gradients to compute GP means and covariances, and the Langstroth method to efficiently draw samples from a large normal from the GP, right? So this is where you're trying to compute the Cholesky, right? This is just saying, okay, this is an efficient way to compute the Cholesky, kind of like in practice. Okay, so this allows us to do backprop through this entire thing and to optimize. All right, so what are some of the things that we did in order to adapt this to our problem? So we had a similar setup, but now we have like multivariate time series. So again, like many different lab values, many different vitals, And we want to be able to use these clinical time series, the baseline covariates, and what we know about when different medications were administered to different people in order to predict whether or not the person is likely to have sepsis. So we can have a new mean function, which depends on medications, right? So obviously, like if you give a medication to a person, you're going to affect their health outcome, right? So if I suspect that you might have some kind of infection, I might give you a medication, and that medication might change how you're presenting or what the measured lab value is. So we try to look, in terms of our mean function, we try to look at all medications that were administered to a particular patient in order to estimate what their lab value might be at a particular time. And then we try to correlate all of the different GPs together. Again, this is important because we have a whole bunch of different time series, right? So we're in this very multivariate setting, and we want to be able to correlate what we see going on in terms of Gaussian process prediction, right? So the way that we do this is a sum of separable kernels, right, where we have sort of the normal GP kernel, which correlates things across time, but then also a kernel which correlates things across all of our different lab values. And we say, okay, we're going to have a sum of these kernels which are separable. And then the classifier that we use in order to make predictions is a recurrent neural net. All right, and so this is basically like some of the data. So this is what some of the trajectories look like. So on the x-axis is hours into admission. On the y-axis is the value, which is going to be different for different ones of these. And so you can see like pulse, respiration rate, et cetera. So these are some complicated functions, and we want to be able to predict what's going on with them farther out and then be able to make this sepsis kind of prediction. And this is an example of what's currently going on in the hospital. So they've got some kind of definition of sepsis, and a person meets it at like varying points in time. And so on the x-axis here is hours since the first time they presented in the emergency department. And on the y-axis is our predicted risk, mean predicted risk for this person. And so the X, the red X, the red cross, is basically when this patient met the clinical definition of having sepsis in the emergency department. And the blue line is kind of like what our algorithm predicts is the likelihood of having sepsis for this particular patient. And so I guess this is really just a demonstration of why you want to be able to use methods like these instead of having these random clinical definitions and waiting until the person meets the clinical definition. Okay, so for this sepsis problem, we looked at 52,000 inpatient encounters for training, and then we had 14,000 for testing, right? So it's like all data from the last 18 months at Duke, and basically we were predicting on 6 months right after that. We had 31 longitudinal variables, 6 vital signs, and 25 lab values, 36 baseline covariates. So there were a bunch of comorbidity, right, like if you have another problem simultaneously, like diabetes indicators, and 6 demographic kind of variables, right, like what's your age, what's your race, that kind of thing. There were 8 different medication classes, so we just really looked at medication by class, right, like were you given this kind of class of medication. And the mean length of stay for a person in the hospital was 121 hours. And so we looked at the algorithm that I just presented to you in terms of how well we did it in terms of like hours before the hospital basically knew that this patient had sepsis, and what kinds of predictions that we were making. And we compared to a whole bunch of different baselines. And we compared to a whole different bunch of sort of like hacked up versions of our own model, right? So it's like, what happens if we take out the medication effect? What happens if we take out the sum of separable kernels and just use sort of like independent Gaussian processes to measure each of these values? What happens if we compare to a random forest, or standard logistic regression? And so we were reasonably happy that we were actually performing better than all of these other methods, right? Certainly the baseline methods, but then also like each of these things that we incorporate, like the medication effect, was actually having a positive effect for the prediction of sepsis in patients. So the left plot is area under an ROC curve, and the right plot is area under a precision recall curve. And so we do this just to have two different measurements that we're getting at the same time. And so one of the things that we're looking at doing, not just in this context, but in a bunch of different medical contexts at Duke, is developing these kinds of web apps for physician use. And so here's the one that we're currently constructing for sepsis prediction. So the idea is that you have a whole bunch of different patients that you're modeling. Each one of these boxes is a patient. And then in the upper left-hand corner is the % risk you think that a person has of having whatever the particular illness, well, in this case, sepsis. On the top is like their name and a little bit of their demographic information, where they are in the hospital, et cetera. And this is what their predicted risk has looked like over time since they've been admitted. What their vital signs are now, what their diagnosis is, and then if their chances of having sepsis gets up high enough, the physician might want to do something like, say, start them on treatment. And so there are a whole bunch of different kinds of bundles that that physicians have that they treat sepsis patients with, right? So there's treatment regimes, and so at least in the U.S., right, like you have to pretty much adhere to one of these regimes once a patient meets certain criteria, right? So they have these very sort of like crude criteria, and then they say, okay, if a patient is meeting this crude criteria, you have to do these things. And if you don't do these things, then basically you get financially dinged. And so we have basically, if you look at one of these patients that have been started on treatment with a high prediction of having sepsis, you see both what kinds of criteria they're meeting currently and what the treatment bundle is that they're currently on. And so in 3 hours, you might want to give them IV fluids. In 6 hours, you might want to assess what their fluid response is, right? And so this web app will remind the physician of this. Okay. How am I doing on time? 10 minutes? Okay. All right, I'll try to give 5 minutes to each of the next two projects. So basically that's some of the recent work, and that's some of the most polished work we have now. We're really focusing on, it's really important to me not to just to be doing this kind of modeling from like a machine learning perspective, but really be trying to incorporate what we're doing into the health system where we are. Right, so we're spending a lot of effort on trying to say, okay, we've got this predictive model. It might not be the best thing, right? And so I'm sure like each one of you is thinking, oh, I could come up with something better than that. And I totally believe it, and I totally love to hear about it, right? But like, you can hopefully see that like what they're doing is so poor right now. Like one of our main goals is just to like take something that's substantially better, start getting it into their workflow, start getting physicians used to looking at like say like these kinds of time series predictions and getting used to working with it, right? Because right now they're not, right? Right now it's just like, okay, you know, I get to make a decision from my gut as like this person's physician, and that, I mean, the overall statement is like we can do a much better job, and so we want to start having that happen. Okay, so really quickly, another project that I've been working on is surgery, so that's predicting surgical complications. So this slide is like, there are a lot of surgical complications. So I think it's 15 out of every 100 surgeries performed results in a complication, and they're really costly, right? So I think in the last year, or in 2014, Duke spent more than $9 million on surgical complications. And we'd really like to reduce that. I really don't care about Duke and how much money it makes, but they really care, and so they'll give me money based on that. So So one of the things that we looked at in order to do this is something called the National Surgical Quality Improvement Program data set. And so that's something that we have going in the US where across different hospitals, they give information about the different surgeries that they have going on, which is nice because a lot of the previous work that I talked about is all local to Duke University Hospital. And this is something national where you have much more data, but a very strict set of variables. And it's very limited. But it's a good thing that people are trying to do. This was a JAMA paper. So JAMA is in the US at least, the most prestigious medical journal out there. And so what they did is that they looked at hospitals and they were like, you know what, hospitals that are part of this NSQIP program, they're not doing any better than hospitals which are not part of this NSQIP program. And it's well, yeah. It turns out it's not enough to just supply data. You have to actually look at it in order to make decisions, in order to see improvement. And so this was apparently a big revelation for them because this was a paper in 2015, maybe 2015. They're we don't get it. And it's so the first thing that we tried with this data is using basically a sparse logistic regression model, right? So this is a very kind of simple thing that we tried to do up front. And it turns out that compared to what's happening now, and again, what's happening now is in terms of evaluating your readiness for surgery, the surgeon is walking in, looking at the patient and going, you look good to go, right? And so that's really, again, the realistic baseline against what we have that we're looking at. But okay, so over here we have a whole bunch of different surgical complications. Any morbidity is any complication, but it could be a cardiac complication, it could be a bleeding complication, etc. And here, using our sparse logistic regression model, this is our ability to predict how likely you are to have it. And so AUC is area under the curve. That's really kind of what we go off of. And so that's pretty heartening in a sense that a lot of people, their complications are actually pretty predictable. Now the next question is, can we do anything about them? And that's a different question, right? So again, when you talk to a physician, one of the things they really care about is not just can you predict, okay, I can predict that this patient is going to do poorly in surgery. That matters absolutely not at all if I can't do anything about it, right? So one of the things that we're really interested in doing is trying to do something about the predictions that we're making. And again, we're kind of in very early days and in terms of trying to do that and evaluating how effective these kinds of prediction algorithms and visualizations are in terms of helping us make interventions that are going to change what somebody's outcome is like. I mean, hopefully it is going to change what people's outcomes are like, right? That's the whole idea behind medicine. Okay, so there are things that you can't do anything about, pretty much the patient has esophageal cancer. That's not really a treatable thing within the context of something that you can get rid of before they go into surgery, most likely. But there are other things like nutritional deficiency, right? So if you know that somebody is nutritionally deficient in some way, one of the things you can do is order a nutrition consult and try to really get them to be nutritionally much healthier before they enter a surgical setting. Okay, so I'm going to skip most of this. We've been trying to do a lot of more complicated things, different versions of hierarchical clustering, different versions of transfer learning, right? Because what I talked about is a national data set, and what I'm working with is really a local population. So how do you say, okay, I know that my national population is not exactly my local population, and then trying to do this preoperatively in terms of consults people get early on. The last thing I wanted to do just really quickly is plug, and let me see if I can do that here, is plug the app that we're about to come out with in a week's time, and it's called MS Mosaic, and a little bit of a difference from what I've been talking about, but the idea behind this app is really to be able to track people's symptoms and it tracks data off of wearable fitness trackers and phone tasks and stuff like that in order to be able to say, okay, somebody's got a somebody's got a chronic disease, and we haven't really been collecting data on this at all on a population level up until now, but we're going to start collecting data on a pretty fine scale in order to hopefully make better diagnoses in terms of what's happening to that person in the future, or what's happening to that population of people in the future. Okay, thanks. Thank you.
Very interesting talk. I was wondering how you're dealing. You just alluded at the end the fact that you've analyzed a particular population and you've developed some models, but population has selected. There's a lot of different types of bias which come in the selection of this population, and if you want to generalize.
To other populations?
Yes.
Yeah. So one of the things.
National database and
yeah.
These are complicated issues. I was just wondering how you're thinking about that.
Let me actually pull up this slide. This is like the thank you slide. So what one of my students, Liz, is doing, so she's actually taking the lead on the surgery project, and one of the things I didn't get to is like the whole idea of like transfer learning within these methods, which within these contexts, which I think is going to be like really, really important going forwards, right? So you're saying you've got access to a particular pool of data, and that particular pool of data looks like this, but you might be interested in, say, like generalizing it to other contexts. So that's like one of the problems that we face in the surgery setting, where we were like looking at like the national data, but we know that we are dealing with our particular local pool of patients, which don't look exactly the same. Right, so what she has is like a factor analysis model. I mean, again, you could think of multiple things to do here, but what she has is kind of like a factor analysis model where she's got like a Dirichlet process prior on the factors, right? So she can pull out different factors to different varying degrees for each kind of like local setting. But it's going to be something like that, right, which says, okay, we think our population sort of globally behaves like this, and then we're going to try to use information that we're getting from the global population to inform our local population, which has a particular kind of substructure that we can learn more about at the local level, but we want to be able to leverage like the very large amounts of data that we're getting kind of at the global level too. I agree, it's a really important problem, and we've just started working on it.
So often in medical applications, it's important to characterize the operating characteristics. So I mean things like whether you're calibrated predictively. That is, if you say that someone's at 60% risk of, say, sepsis, do 60% of the people you say are at 60% of risk get sepsis. Have you looked at whether you're kind of, in a sense, calibrated in a frequentist setting in terms of your risk kind of scores or profiles?
Yeah, I'm not sure I understand exactly what you're asking, but so there are a couple of things that are going on, and I'm trying to think of exactly what you mean. But so you're obviously better off trying to get some sense of like, say, like what your variance is, like what your confidence intervals are, in terms of how confident you are in the predictions that are being made. Like there's some amount of like us running clinical trials in order to say, okay, we're making these predictions, how well do we feel like this is actually generalizing when we look out like prospectively, like in time. There's some amount of us looking at different ways you could actually measure risk and trying to sort of like show physicians risk in different ways, right? So you can like look at somebody's absolute risk of something happening, you can look at somebody's relative risk of something happening. Those can be two very different things. There are a lot of kind of complicated questions. I mean, and I know you're more getting at like how statistically stable is what you're doing, but like there are a lot of really complicated questions I think going on there, even just with like, you know, do you really care about absolute risk, or do you really care about, how much risk this person has compared to the population as a whole, or whatever, that are probably like even bigger effects than like we're just doing a crap job at our statistics, which might be true too, but probably not. I mean, this is probably at least better than the really terrible things that are going on right now, right? And again, that's why I'm like, I'm totally open to doing something even better than this, but I just, want to see something better than a threshold or like a physician walking in and making a judgment. Yeah.
I was wondering, actually, a little bit of a follow-up to that question. So, the doctors are going to be seeing whatever you're reporting, be it some like percentage risk or something else like that. Do you have the capability to do like user studies with the doctors to know to what extent they're able to actually use the information as you're providing it?
Yeah, so basically we're at the very beginning of trying to do that at Duke, right? So it's like, okay, you create a web app, kind of like the web app that I showed for sepsis, right? And you present that to a physician. And right now in the hospital system, they're much more skeptical about like automatic decision making. So one of the things machine learning as a whole is really into, at least machine learning as a whole, is really into is this idea that like computers are going to replace doctors. And probably the truth of the matter is there are a fair number of times where I can get some kind of method to actually make a better judgment than a doctor. But the university health system isn't really open to that at this point. So it's more like we're going to show physicians information and see how their decision making changes and like whether people's outcomes improve. And so we're kind of like at the very early days of running these kinds of trials where we're saying, okay, like look at this dashboard. What do you think? Is this actually affecting the decisions that you're making? Is this actually improving patient outcomes? I think it's a really interesting question.
Yeah, I guess I wonder, just a very quick follow-up with that, especially with like some of the models you had, you can imagine that there's some interpretable aspect of that, like, oh, here's like the population level, here's the subpopulation, here's the individual, and I wonder if there's like some summary that could be created from that would be, potentially like more readable by a doctor.
Yeah, no, that's right. So we try to, I haven't successfully in every single case that I've presented to you right here, right? But we try to keep our methods as interpretable as possible just because you're right, they're going to be totally at a lie, right? If it's coming down to like, you've got to show this to a human being and have them have some understanding of what's going on, which we do at least right now in, interactions between these kinds of methods and doctors, right? It's like really, really key that they be interpretable. And so certainly, like you can imagine, like the baseline thing I talked about with surgery was like logistic regression, right? Like you can imagine with logistic regression, you're like learning particular weights on different sort of variables, right? Like that's something that's kind of interpretable to physicians, right? It's like, oh, you're weighting like nutritional deficiency really highly in this prediction. Let me try to do something about that. No, it's really important. I agree.
We can carry on discussions over tea. So we'll try and start again at 11. We've run slightly over.